Our next topic for the day is congestive heart failure. The definition for it is failure of heart to pump blood at rate to meet the needs of the tissue. What this actually means is if the tissue needs 10 amount of blood, the heart is only able to pump 7. You know what I mean? So it is the failure of heart, it cannot pump 10. So failure of heart to pump blood at a rate to meet the needs of the tissue. The rate is 10. It is not able to pump at 10 rate, so failure of heart to blood pump blood at rate failure of heart to pump blood at a rate to meet the needs of the tissue. Causes. What are the causes? In the first week of life, if there is heart failure, then it could be birth asphyxia, myocarditis, hypocalcemia, CHDs as AS or PS, and atrial stenosis or pulmonary stenosis or hypoplastic left heart. So in first week of life, what all things could be there? That could be birth asphyxia. As soon as the child is born, he may not be able to breathe, so his heart may not be his heart may get damaged. Myocarditis, because obviously if the muscle is inflamed, it will not be able to pump properly. Hypocalcemia, the calcium is very important for any muscle to contract or relax, and if there is hypocalcemia, obviously the heart won't be able to pump. CHDs, that means atrial stenosis or pulmonary stenosis. That means if there is stenosis in the aorta or atrium, I don't know what it signifies here. It could be atria or pulmonary, aorta or pulmonary, mostly it must be aorta. So if there is stenosis, then obviously even if the heart is pumping, the aorta will not be able to receive the amount of blood that the heart is pumping. So that's why. And hypoplastic left heart. So hypoplastic and hyperplastic. Hypo means less, plastic means less, plasticity is less, and left heart. And then if it is 1 to 2 months, large VSD and PDA. If 2 to 6 months, VSD, PDA and coarctation of aorta. And in older children, there could be RHD and acute rheumatic fever. Cardiomyopathy, CHD complication by infection, anemia, infective carditis. So what all could be the reasons? In first month, first week of life, there could be birth asphyxia, hypocalcemia, myocarditis, or AS or PS, or hypoplastic heart. In 1 to 2 months, there could be CHD, VSD or PDA. In third month, there could be VSD, PDA or coarctation of aorta. And 2 to 6 months, sorry. And older children, there could be RHD and acute rheumatic fever. What are the clinical features? There could be normally, what do you see? You see tachycardia, you see tachypnea, you see hepatomegaly, you see feeding difficulty, and you see basal crepitations. Basal crepitations, feeding difficulty, hepatomegaly, feeding difficulty you see in children obviously, and then you'll see tachycardia. In infants you'll see poor feeding, sweating over forehead, and tachypnea. These all things you should remember, because in PDA also you'll see this, in VSD also you see this, and then you'll have to write in the answer. So remember tachypnea, tachycardia, poor feeding, you'll see sweating over the forehead, and then you'll see basal capitation, poor weight gain, failure to thrive, loss of calories due to increased work of breathing. Poor weight gain is a constant hallmark of in young children. In older children there will be dyspnea on exertion, and there will be orthopnea. There will be breathlessness on lying down, edema, raised JVP, basal crepitations, liver enlargement, and gallop rhythm. So what all things? In older children you'll see dyspnea, and you'll see orthopnea, you'll see edema, raised JVP, basal crepitations, liver enlargement, gallop rhythm. Investigations. In ECG, ECG may show underlying condition, 2D echo, diagnostic underlying condition. What all things you'll do? ECG will do, 2D echo will do, chest X-ray will do. In chest X-ray, you will see cardiomegaly. So you'll rule out other respiratory conditions. And in routine investigations, you'll see HB, CBC, CRP, and you'll rule out other comorbidities which are there. What all things you'll see in investigations? Let's remember. First, you'll do 2D echo, you'll do ECG, you'll do chest X-ray where you'll see cardiomegaly. Then you'll rule out other possibilities. You'll have CBC, HB, CRP, and electrolytes. What are the steps in treatment? Correct the underlying cause. So if there is hypocalcemia, give calcium. If there is tachyarrhythmia, then give beta blockers. Supportive measures: reduce physical activity. May be difficult in children. So if a child is running around, it will be difficult for him to stay at a place, but you'll have to try to make him sit. Incline the child at 30 degree to pool edema fluid in dependent parts and decrease the work of breathing. You have to incline the child at 30 degrees Celsius to pool the edema. Then treatment of fever and anemia, mechanical ventilation if required, humidified oxygen, head and elevation. So if he is sleeping, you'll have to elevate the head. If while he is sitting, you'll have to do a 30-degree inclination. If he has to sit somewhere, you have to treat fever and anemia. You'll have to do mechanical ventilation if required. You'll have to give humidified oxygen. You'll have to do reduced physical activity, and then you'll do supportive measures. So, cause specific treatment you'll do, supportive treatment you'll do, then contractility, stroke volume, preload, afterload, heart rate, cardiac output, all that. Drugs, what drugs you'll give? In drugs, you'll give preload reduction, diuretics you'll give so that the load on the heart reduces, and it is a mainstay of treatment. Action starts in 20 minutes, and you'll give furosemide. After load reduction, AC inhibitors you'll give. Safety and efficacy proven in children. Contraindications are renal dysfunction and hypovolemia. Cough is troublesome side effect. Increase myocardial contractility, you give ionodrops and digoxin. Generally, what you give in CCF, that only drug treatment you'll give. For preload, you'll give diuretics. For afterload, you'll give AC inhibitors. And for myocardial contractility, you'll give digoxin and ionodrops. In management of acute CCF, you'll give mechanical ventilation. Inotropes like dopamine, dobutamine, adrenaline, noradrenaline, levodopa in acute decompensated CCF with shock have short-term benefit in improving symptoms. Dobutamine has advantage that it does not require central line for administration. Inodilator, milidrone. So you'll give inodilator, milidrone. You'll give dobutamine because it does not need central line. You'll give inotropes such as dobutamine, adrenaline, noradrenaline. You'll give mechanical ventilation. In drug treatment, you'll give AC inhibitors, you'll give diuretics, and then you'll give digoxin. And otherwise, you'll treat the basic cause, you'll give supportive measures and reduce the physical activity, 30-degree inclination, treatment of fever, mechanical ventilation, and humidified oxygen. In investigations, you'll do ECG, X-ray, 2D ecography, you'll do ESR, HBC, CBC. And then in clinical features, you'll see tachypnea, tachycardia. You'll see difficulty in feeding. You'll see sweating over forehead. Then you'll see dyspnea or exertion in children. In orthopnea, you'll see poor failure to thrive. And basal crepitations you'll see. Remember that. Basal crepitations, tachypnea, feeding difficulty, orthopnea, dyspnea and exertion. What all could be causes in first year of life? There could be birth asphyxia, hypocalcemia. Then there will be myocarditis and hypoplastic left heart. 1 to 2 months large VSD, PDA. 2 to 6 months VSD, PDA, coarctation of aorta. Older children, RSD and acute rheumatic fever. Failure of heart to pump is the definition. Thank you guys.